This is a great group. I'm excited to talk about valvular disease of the heart. Hopefully, you can hear me okay. I'll just introduce myself. I'm an interventional cardiologist by training. I'm originally from upstate New York, so I've lived in many places, and I've trained in. Oh, how about now? Okay, good. So I'm originally from upstate New York. I grew up in a small town, and my background actually was not medicine. My training was in music. So when I started out, I was a piano player. I played classical piano. I trained in classical piano, and I did that for about 20 years. And it was in college when I realized that even though I loved music and I loved piano, it wasn't going to be a long-term career for me. It was probably the most competitive field I've ever been in. So if you know anybody in music, it's really competitive, and the people that excel are absolutely fantastic. But it wasn't for me. So I had a love for science and decided to pursue medicine, like some members of my family. Cardiology, I was drawn to cardiology because, like music, it involved listening. I feel like my background in music tuned my ear. So cardiology is a lot of listening. We listen to the heart, how it beats, how it sounds. Are there murmurs? Where are the heartbeats? We read. So we look at EKGs, kind of like looking at a score of music. So reading an EKG, we can learn a lot about the heart. And of course, there's imaging tests, there's echocardiograms, there's CAT scans, there's things we're going to talk about during this talk. It kind of melded for me. So I was drawn to cardiology early in medical school. I'm an interventional cardiologist. That means I do procedures, minimally invasive procedures on the heart to treat conditions like coronary artery disease. But I'm also participating in procedures that fix heart valve problems. So we'll go into some of the procedures that we do as structural cardiologists. It's a privilege to talk to this group about valvular diseases of the heart. This is a huge topic. In fact, every year I go to a couple of conferences, national conferences, and the conferences are typically 4 days long, full days, just talking about valvular disease of the heart. So we're going to kind of squish that into 45 minutes, hopefully this morning. Um, I am a speaker for Abbott Structural Heart, so that's my only disclosure. So today, our learning objectives are we're going to explain the basic structure of the heart and circulatory system. I'm going to describe the role of the heart valves. We'll talk about the 4 different heart valves and what their functions are. We'll discuss some common heart valve conditions. There are many, many heart valve conditions, and we'll talk about some of the common ones today. We'll recognize symptoms of valvular heart disease, and we'll highlight some contemporary treatment options for common valvular heart diseases. So the first thing I tell my patients when I see them in clinic, I'll tell you a lot of people come to me and they're pretty nervous or anxious because they've been told they have a heart condition. The heart can be a complex thing, but really it all boils down to a pump. Our hearts are pumps. So just like any pump, our heart has structure. It has components that generate force, pushing fluid or blood forward. The muscle is the component that pushes blood forward, generates force. Muscle in the heart is called myocardium. So every time our heart beats, it's because that muscle is squeezing, the heart is pumping, and it generates the force needed to circulate blood through our body. The blood will move forward from the heart. It'll travel through our organs, our bones, our muscles, and then return to the heart to be recirculated. All of that energy comes from the heart, the muscle in the heart. So the heart has 2 sides. It has the right side and the left side. The right side of the heart receives blood coming from the body, coming back from the organs and the bones and the muscles. That blood will be pumped into the lungs from the right side of the heart. That blood will pick up oxygen in the lungs and get rid of carbon dioxide, which is a waste product of metabolism, and then that blood will be returned to the left side of the heart and will be pumped to the body to be recirculated. So the lungs sit between the right and the left side of the heart as far as the circulation is concerned. So to generate a heartbeat, there has to be some kind of stimulus. So the heart has an electrical system that's built into it. So every heartbeat that happens because there's an electrical impulse. And that electrical impulse typically always starts at the top part of the heart, called the atria. Let me see if I can point here. So this is where the impulse starts. This is the natural pacemaker we all have built into our hearts. And that electrical impulse will travel from this point down through this conduction tissue all the way to the bottom of the heart. This should happen in a very organized way. As long as it's happening in a very organized way, our hearts will beat normally. If you've heard of people that have arrhythmias, it's because there's a problem with the electrical system in the heart. And then the heart has plumbing. So plumbing in the heart is a combination of blood vessels and heart valves. So blood vessels, these are the coronary arteries, and I'll just point to these, hopefully. Oh, let me try my mouse. Sorry. So these are the blood vessels in the heart, coronary arteries, and also the coronary veins are drawn here. So I mentioned that the heart has muscle, the myocardium. The myocardium is pumping all day long. That means the muscle's working all day long, all night long, never stops. Never stops for our entire lives. In order for that muscle to continue to work properly, it needs a continuous supply of blood. The coronary arteries will supply blood to the muscle of the heart. If you've ever heard of somebody who's had a heart attack, it's probably because they had a blockage in a coronary artery, these small blood vessels here. So if they have a stent that was placed or if they have bypass surgery, it's working on these small arteries here. Okay. And then the heart has valves. So the second part of the plumbing. Valves are one-way doors that allow blood to move forward. So the force is generated by the muscle of the heart. The myocardium will push blood through the valves, and the valves will open to allow blood to move in one direction, and then they close to prevent blood from moving backwards. So we'll talk about the inside of the heart. This is a little bit of cardiac anatomy. The heart has 4 chambers. The upper chambers on either side, these are called the atria, and the bottom chambers are called the ventricles. The atria are meant to collect blood coming from somewhere. So on the right side of the heart, which happens to be on the left side of this picture, the right atrium is collecting blood coming back from the organs and the muscles and the bones after that blood has delivered oxygen, delivered nutrients, picked up carbon dioxide as a waste product. So the right atrium is collecting all that blood coming from all the veins and then delivering that blood through this valve called the tricuspid valve into the right ventricle. The right ventricle is then pushing that blood through the pulmonic valve into this pulmonary artery, and then the lungs are above this picture, not drawn. It's in the lungs that the blood picks up oxygen and delivers carbon dioxide. The lungs will deliver blood to the left atrium. You can see the color of the blood is different. So you may know that the reason blood is able to carry oxygen is because it has a protein called hemoglobin. Hemoglobin turns red when it's saturated with oxygen. So blood coming back from the lungs is saturated with oxygen, the blood will look red. And that's why it looks red in this picture. When hemoglobin gets rid of oxygen, it reflects and absorbs light differently, so it looks more purple. So that's why the blood looks dark or purplish when it's coming back to the heart after circulating. So a few words about heart valves. So heart valves, like I said, they're one-way doors for blood flow. They allow blood to flow easily forward, and they prevent blood from flowing backwards. Heart valves are strong and durable. Typically, they're flexible flaps. They open and close with each heartbeat. A lot of people think that the valves have muscles built into them or some kind of mechanism that causes them to open and close. They actually don't. They're they're built to respond to pressure changes in the heart. So it's the muscle in the heart, the myocardium, that generates the force to push blood into the valves, and it's that force that opens the valves. And of course, the valves are essential for normal heart function. If there's a problem with a heart valve, typically that can lead to symptoms. It can lead to serious health problems. I think I'm going to have to get right up into this microphone. So there are four heart valves. We'll start over here on the right side of the heart. The first valve we'll talk about is a tricuspid valve. So that's the valve that separates the right atrium and the right ventricle. The tricuspid valve facilitates blood flowing from the right atrium into the right ventricle and prevents that blood from moving backwards. So if the tricuspid valve is functioning properly, we have good, efficient forward flow through the right side of the heart. But if there's a problem with the tricuspid valve, for example, if the tricuspid valve is leaking, that can lead to symptoms, backflow of blood backwards through the valve, back into the right atrium. That can increase the blood pressure in the right atrium, which translates to increasing blood pressure into all the veins in the body. This can cause things like swelling. A person may have leg swelling if they have a severe amount of tricuspid valve leakiness. It can cause fatigue and sometimes shortness of breath as well. So normal tricuspid valve function is important for blood flow through the right side of the heart. And then when the right ventricle contracts, it's pushing blood through the pulmonic valve and to the lungs. The pulmonic valve will prevent blood from leaking backwards into the right side of the heart. So very important right-sided valves. On the left side, we have a similar setup, slightly different valves, but similar setup. We have the blood returning to the left atrium from the lungs, going through the mitral valve from the left atrium into the left ventricle through the mitral valve. And again, the mitral valve, similar to the tricuspid valve, it's preventing blood from moving backwards back into the left atrium. If that blood moves backwards into the left atrium, it's going to increase the blood pressure in the left atrium, which will translate into increasing blood pressure in the blood vessels in the lungs, which will cause symptoms like shortness of breath. It can lead to fluid buildup in the lungs and a condition called heart failure. The left ventricle is pushing blood out through the aortic valve into this big red blood vessel called the aorta. The aortic valve is the main outflow valve of the heart. It's probably one of the most important valves in the heart because if there's a problem with the aortic valve, people typically are going to feel it, especially if that problem becomes severe. The aortic valve's function is essential for forward flow. If the valve is leaking, the blood will leak back into the left ventricle. This can cause excessive strain on the left ventricle. If the valve is stuck, if it doesn't open all the way, that as well will cause excessive strain on the left ventricle in a slightly different way. All of these valves are essential, and normal function is important for all of us. Okay. So how do we see? So, people are often referred to me for an opinion regarding their heart valve problems. How do we know they have a heart valve problem? Well, really, the first thing is listening. So even before we see, we listen. And typically, the patient's primary care provider will listen to the heart during an exam, may notice a heart murmur. We'll talk about murmur in just a moment. But the heart murmur is the sound that blood makes as it goes through an abnormal heart valve. To confirm a problem, now we have ultrasound or echocardiography. So echocardiography is really cool technology. We rely on this, and this allows us to see the heart in real time. Echocardiography is really cool technology. I love technology, and this one is one of my favorites. So just like any ultrasound, what this does, it's a probe that somebody puts against your skin, and it shoots sound waves into the chest. The probe will receive the echoes coming back from the sound waves that were put into the chest, and it will turn the echoes into a picture based on the frequency of sound that comes back to the probe and how long it takes for the sound wave to come back. So it's a really cool technology. It's way more technical than I'm able to explain, but it works amazingly well. And we're able to see things like in this picture, all four chambers of the heart, including the mitral valve right here and the tricuspid valve over here. We've got the two ventricles and the two atria. On this side, we're looking at the heart from a different vantage point. This picture was taken using transesophageal echo, which is an ultrasound probe at the tip of a scope that goes into the mouth and down into the esophagus while somebody is sedated. But this allows us to see in very high detail the structures of the heart, in this case, the mitral valve, which has some problems. You can see down here, this mitral valve is leaking. So the other thing that echocardiography allows us to do is see how blood moves in the heart. And it does that by tracking the movement of blood through the heart by using a technology called Doppler. So Doppler imaging is super important with cardiac imaging. In this case, you can see that there's leaking, this yellow mixed with blue and red, pushing backwards. This is blood leaking backwards from the left ventricle into the left atrium through a mitral valve that's not working properly. And then here's a look at a nice healthy aortic valve. Looking at it from the side, we call this the long axis view. You can see that we can see these heart valves with very good detail, and we're able to diagnose and plan treatment based on this test. We also have angiography. This is a procedure that interventional cardiologists and cardiologists specialize in. You may know somebody that had an angiogram. So this is what we're talking about when we say angiogram. So up here on the top left, you can see that there's a catheter, which is a long skinny tube. This particular catheter was placed through a small blood vessel in the wrist, and that catheter just follows that blood vessel all the way to the heart. We position in a coronary artery, and we inject dye into the coronary artery. So here you can see very nicely the blood vessels in the heart, those coronary arteries. We're looking for blockages. In this case, and in this particular picture, there are no blockages. So this person had very nice, clean, open coronary arteries. We use X-rays to get these images, X-rays and contrast dye. And one thing you may notice with X-rays, you really can't see the heart. The heart is soft tissue. There's no bones in the heart, no calcium, things that show up well on X-ray. So in order to see, we have to inject dye. So the heart is actually here, and the blood vessels traverse the outside of the heart. Now down here in the bottom right, we're going to talk about valve replacement. This is a procedure called TAVR. And in this clip, we're in the middle of implanting a heart valve in the aortic position. So TAVR is a procedure where we use catheters rather than open heart surgery to replace heart valves, in this case, aortic valve. So we're able to see, again, we're injecting contrast so we can see. Of course, we can see our equipment very well. So angiography, this is another way that we see. And then another technology that I think is important and definitely worth discussing is CAT scan. So now we have modern CAT scan technology that allows us to see the heart in incredibly high detail. This is very important when we're planning valve procedures. So up here on the top left, we're looking at an aortic valve. I've colored each of the leaflets. I've color-coded them so that I can quantitate the amount of calcium buildup in each of these leaflets. That's an important thing to know as we're planning valve replacement. Over here on the right, this is a picture of the aorta. The heart's down here, kind of canceled out of this particular image, but this is the aorta. And I can see that the arteries going to the brain and the arms, these are normal. There's a little bit of calcified plaque here, but the rest of the way is clear. This is important as I'm planning a valve replacement procedure. And then we get all kinds of measurements on the bottom left. You can see this is a aortic valve. We'll talk more about that valve configuration in a moment, but it has 3 nice leaflets, and I'm taking measurements here, again, to plan valve replacement. So incredibly important technology. It doesn't just do aortic valve planning imaging. We use it for many other things as well. It's easy. By the way, if you ever need to have a heart CAT scan, you get an IV in your arm. They do inject dye into the IV so that the CAT scan can see the structure of the heart, but you go home after about a 10-minute study. All right. If anybody has any questions or comments, feel free to just raise your hand to make this as interactive as possible. So I was thinking about what would be the most interesting way to talk about these heart valve problems, and I always like to discuss a case because I think it's most engaging, and I think it illustrates best what we're able to do. So we'll talk about a couple of common heart valve problems in a case-based format. So these are real cases, real patients that have come through that I've seen. This person is 77 years old, very thin, has a low body mass index. She has chronic heart failure symptoms. So when I met her, she's very active, but she's limited in what she's able to do. She tells me, Doc, I'm feeling short of breath when I'm trying to do my gardening. She has a husband who has some chronic medical problems. She cares for him, but she's feeling short of breath and tired and not able to care for him the way that she feels she needs to. She has a KCCQ score of 36. So what is this? This is the Kansas City Cardiomyopathy Questionnaire. Everybody coming in for a valve procedure, we do this questionnaire, and this helps us determine how much are her heart problems contributing to how she feels. And in this case, with a score of 36, that's a pretty low score. It's on a 100 scale, 100 being feeling great, 0 being feeling absolutely terrible. 36 is a low score. This means that her heart valve condition was really impacting her life. Other medical problems, she has lupus, high blood pressure, she has some thyroid problems, and also some osteoporosis. So pretty common medical problems. On physical exam in the office, she had high blood pressure. She was very sharp, cognitively and neurologically intact. She had a loud murmur. We grade heart murmurs on a 6-point scale. So she was a 3 out of 6 murmur. That's pretty loud. And her lungs were clear. So I didn't hear any fluid in her lungs. Importantly, her functional status was excellent. She's very active. As I mentioned, she cares for her ailing husband. She's independent. She has a CAT score of 6 out of 6. That means she does all of her activities of daily living on her own. Cooking, she's able to dress herself, clean. Everybody that comes in, we do this score, and she scored perfectly. She has a walk speed of 1.5 meters per second. We test how fast people walk. This is a measure of frailty. So she was a little slower than normal. And this was, I think, due to her valve condition. But this is one way that we measure how frail somebody is. Everybody gets these tests when they come into the office. Similarly, we always test grip strength. That's another measure for frailty. She was a little weak on the grip strength. So she has some frailty markers. By the way, why do we check frailty? Whenever somebody comes in for a valve condition and we're considering valve replacement, we have to help make a decision about whether or not open heart surgery versus a catheter-based procedure would be better for them. And frailty plays a role. If someone is frail, they're going to have a harder time recovering from open heart surgery. So that may make open heart surgery less desirable in those cases. Okay, so here's her echocardiogram. If you've seen a million of these, you would pick up right away that the aortic valve is not normal. So here's the aortic valve here. This is our long axis view. And you can see there's calcium that is built up. This white stuff, this thickness, that's calcium that's built up in the aortic valve. And over here, we're looking at the aortic. Sorry about the video, it's a little choppy. But over here, we can see the aortic valve in short axis. That means we're looking at it on FOSS. And we see that there are 3 leaflets. There's calcium buildup in these leaflets, 1, 2, 3. And the calcium is preventing the valve from opening normally. We're going to talk about the structure of the aortic valve in just a moment. The strength of our heart is normal, so that's really good. And then over here, we're using Doppler imaging to track blood flow. I won't go into this in too much detail, but I will tell you that what we're seeing here is the speed of blood. In this case, the speed is on the scale going down over time, which is the horizontal axis. And we can see that the speed of blood is pretty fast, 4 meters per second over here. This is the cutoff for severe aortic valve stenosis. Stenosis is the word we use for a valve that doesn't open all the way. If it gets beyond 4 meters per second, that's the cutoff for a severe aortic valve stenosis case. If you think about blood flowing through the aortic valve, I often ask people to think about their hearts like a garden hose. So if you're out there watering the lawn with a hose and you stick your finger halfway over the outflow of the hose, you know what happens, right? The water will speed up, it'll kind of squirt out farther and faster. That's exactly what happens in the heart. So if you have aortic valve stenosis, if your aortic valve is only opening halfway, the blood's going to be passing through that valve faster. It's going to squirt out of the valve faster and harder, and we're able to detect that on the echocardiogram. So she has severe aortic valve stenosis. We'll talk a little bit about the aortic valve. So the aortic valve, as I mentioned before, it's the main outflow valve of the heart. It enables forward flow of blood from the heart into the aorta. And it's composed of 3 thin and flexible leaflets or cusps. These open and close in response to pressure changes in the heart. So again, there's no muscles built into the valve. They're responding to the muscle of the heart as it's pushing blood from the left ventricle. And it's very efficient. It's designed to last a lifetime. It's very durable. These 3 parts called leaflets, they're very durable. They're living tissue. That means if there's an injury, it's going to try to repair itself. It has its own blood supply. And they're very silky and smooth to minimize turbulence. So if you think about it, this valve is opening and closing with every heartbeat for our entire lives. That blood, as it passes through the valve, it's going to create, there's some friction. So the valve is designed to resist degradation from that continuous friction over a lifetime. But the valve can have problems. Aortic valve stenosis is what we were just talking about. The valve can become narrow and unable to open properly. We call that stenosis. This top picture shows a valve that has stenosis. So you can see hopefully the 3 leaflets and then this nodular looking stuff. This is calcium that has built up inside of the tissue that makes up those leaflets. And the reason that happens, there are several reasons, but basically, as inflammation happens inside the tissue that makes up the leaflets, it causes some swelling and some calcium deposition inside those leaflets. That's how the immune system responds to inflammation. When there's calcium that starts to build up, there's turbulence that forms as blood is flowing past this small, tiny, microscopic calcified nodule. It's going to create turbulence. That turbulence can irritate the valve tissue more and repeat the inflammation. So this happens over and over again, and the calcium can build up steadily. So this is calcified aortic valve stenosis. Similarly to stenosis, which is a problem where the valve doesn't open all the way, it's possible that this same process leads to the valve not closing all the way. So up here on the left, we have a valve that's trying to close, but because of the calcium buildup, it doesn't close all the way. This causes leaking from the aorta back into the left ventricle. We call that regurgitation. Rheumatic aortic valve disease, not so common in the United States, but very common in other parts of the world. This is a condition caused by untreated group A strep infection. So typically the way this works is a child will have a really bad sore throat. Maybe they have fevers. They might have a rash. And they're in a part of the world where antibiotics are not readily available. Or perhaps it's just not recognized that this is a condition that needs to be treated with antibiotics. So they're not treated. the strep infection runs its course. But what happens is it triggers an immune response that slowly causes inflammation of the heart valves over time. So by the time they get to early adulthood, their aortic valve may look like this. So the three leaflets, you can kind of see them. There are three here, but there's this fibrosis or scar tissue that has built up on these leaflets, and they've kind of come together because they've fused because of this scar tissue. So this is rheumatic aortic valve stenosis. And then there's a condition called bicuspid aortic valve. This is the most common congenital heart abnormality out there. So bicuspid aortic valve is a condition where somebody is born with two leaflets instead of three. So here's a two leaflet valve over here. You can see that there's this line. This is where two of the leaflets did not separate during the development process. So this is bicuspid aortic valve disease. About 1 out of 100 people have this. This can cause early valve degeneration. So typically, if somebody's going to have aortic valve stenosis from bicuspid valve disease, it's going to happen when they're in their 50s or 60s, as opposed to when they're in their 70s or 80s with a trileaflet valve. What about the clinical findings? So if somebody comes in and they have severe aortic valve stenosis, typically they're going to be feeling short of breath. They might feel dizzy with position changes. They might have some chest discomfort. Orthopnea, that's a condition where people lay down in bed. Maybe they're going to bed at night, but they feel out of breath when they lie down, so they have to elevate the head of their bed or have multiple pillows. And typically they feel fatigued or tired. So these are the classic symptoms of aortic valve stenosis. And then on physical exam, there's probably going to be a heart murmur. That might be the first thing that's picked up. Heart murmur in aortic valve disease. Typically on the loud side, you can see up here letter B. This is a diagram of the heart murmurs, and it's during a period called systole. So this is when the heart is squeezing, when it's contracting and pushing blood through the aortic valve. That's when that murmur is going to show up. So if you're listening to the heart, you'll hear a murmur. It gets louder, and then it kind of tapers off during that first part of the heart cycle called systole. And then when the heart is relaxing and filling back up with blood, it's typically going to be quiet. So this is the murmur most associated with aortic valve stenosis. If you have your finger on the pulse, you might notice pulsus tardici parvis. So what that is, it's a pulse that it happens slower than normal. So the upstroke is slower because, of course, the blood is having a hard time getting through that aortic valve. And the peak of that pulse won't be as high. So tardici parvis. If the valve is leaking, you might get this thing called water hammer pulse. That's a really prominent pulse. It feels like a water hammer. It just feels super powerful. The impact is very strong. And that's because when the aortic valve is very leaky, blood is rushing back into the left ventricle between each heartbeat. And when the heart squeezes, the next heartbeat will always be really strong because it has so much blood. Okay, well, let's get back to the patient. So this is our 77-year-old female who was found to have severe aortic valve stenosis. Here's our angiogram. So we looked at all of her coronary arteries. This is a standard part of the workup for valve replacement. All the coronary arteries look normal. Then we did a CAT scan. The CAT scan allows us to take very precise measurements of all the structures in the heart. I won't go into these in that much detail, but here you can see her aortic valve, her 3 leaflets. We take all kinds of measurements. Again, we're measuring what's the exact size of the valve. We're going to be putting a new valve in there, so we want to make sure we understand the dimensions. We're looking at the coronary arteries. Where do the coronary arteries take off? What is the height above the aortic valve? So we can see the left coronary artery, the right coronary artery. So this is part of the standard workup. And then here's her aortic valve. You can see over here, this white stuff is calcium buildup, color-coded, and then I can actually quantitate the amount of calcium in her aortic valve. I'm able to measure her root angle. So these are, again, the valve replacement is very technical. So we take all these measurements so that by the time somebody comes in for a valve replacement, the procedure is almost done. 90% of the procedure is done, I tell people, because that's the planning phase. By the time they come in for a valve replacement, everything's been planned. We know everything about the inside of their heart and body, and that's because we have this CAT scan technology. And then this is the blood vessels going from the legs up to the heart through the aorta. So we need to know how big are these blood vessels. If we're going to do a catheter-based replacement, we're usually going to go through the arteries in the groins. So we want to make sure we can get there. And what are the treatment options? If somebody has severe aortic valve disease, we basically have 4 treatment options these days. We have medications, we have surgery, we have balloon procedure. This is called valvuloplasty. We can open up the valve using a balloon, or we can put a new valve in there, and that's called TAVR. And I see I'm already running short on time, so I'm going to speed through a couple things. But we have this team called the Heart Team, and it's a combination of interventional cardiologists, heart surgeons, cardiac imaging specialists, anesthesiologists, the referring providers, heart failure specialists. Everybody coming through that is going to have a valve procedure will go through our Heart Team process. We come up with a shared decision for what the best treatment option is for the patient. So we decided TAVR would be the best treatment option for this patient. TAVR is minimally invasive. What we do is we bring a new heart valve into the heart and we implant it. So here you can see one of the types of heart valves that we use. This is called the Navitor valve. We're able to position or reposition the valve. In this case, the valve was a little too deep. So we're going to make it a little less deep. We don't actually remove the aortic valve. We keep the aortic valve in there as we implant the new valve into it. So with TAVR, it effectively replaces the valve by implanting a new valve inside the diseased valve. And that's the completion of the valve deployment. And we use contrast to see, we're using x-rays to see, we're using echo to confirm. What we're not doing is opening up the chest. So this is not open heart surgery. To get access to the blood vessel, it's just a little needle that goes into the blood vessel. So when the patient's done with the procedure, they leave with a tiny little speck, I should say a scab that just falls off. That was where we access the blood vessels. Okay. This is what we see. So on the left, we're advancing the valve. This is how we see it in the procedure area. On the right, we get the valve in position. We're confirming our position. And on the left, we have partial deployment. And on the right, we have our fully deployed valve. And we have confirmation on the left that our valve is in very good position. For the sake of time, I'm not going to get into this technical thing called commissure alignment, but this is a very important part of what we do. And then this is the echocardiogram the next day. The valve looked great. There were no major problems. The patient felt wonderful immediately after when she woke up from the sedation. Let's see, here we go. And this is the valve we used. It's called a Navitor Vision valve. He was discharged home the next day. All right, so don't have a lot of time left, but we're going to talk about one more case. 73-year-old female, she is obese, has chronic heart failure symptoms. So again, she feels short of breath with exertion. She has diabetes and high blood pressure. On exam, she was hypertensive, but otherwise the exam was normal with the exception of heart murmur. She also was very physically active. She likes to garden, do housework. She ambulates independently. She was not frail. This was her echocardiogram. So this is mitral valve now. You can see on this image there's a little gap between where these two leaflets come together. And over here on this image, sorry, there's a little image degradation, you can see a big leak here. So blood moving from the ventricle into the atrium. So this is mitral valve regurgitation, and in her case, it was severe. So what about the mitral valve? It facilitates blood flow between the left atrium and the left ventricle. It has two thin, flexible leaflets that open and close in response to pressure changes in the heart. And it's supposed to prevent backflow of blood from the ventricle into the atrium. In her case, there was a severe amount of blood flowing backwards into the left atrium that was causing significant shortness of breath. So when she tried to do activity, she was feeling out of breath. I mentioned before on her exam, she was obese, so that made it even harder for her to get around. It also made the risk of surgery higher for her. So remember, we consider everybody for surgery versus transcatheter treatments. Her risk was considered high. The mitral valve can have several problems. One is mitral valve stenosis, where the valve doesn't open all the way. That can happen because of calcium building up in the valve itself. It can also happen because of rheumatic valve disease. So just like the aortic valve, the mitral valve can be affected by rheumatic fever. This is a valve that was affected by rheumatic fever. You can see how thick it appears. This is very abnormal. This valve needs to be replaced. In mitral valve regurgitation, like our patient, this is the most common condition with mitral valve disease. The valve does not close properly for one of various reasons. Patients may feel out of breath, tired, orthopnea. Again, when they lie down, they may feel out of breath. They may notice leg swelling. That's a common symptom. On exam, they have a heart murmur. Again, this particular problem, mitral valve regurgitation, occurs during the active phase of the cardiac cycle. So that means the heart's squeezing, blood is moving backwards through that valve, and that makes a low-pitched murmur that we can hear when listening to the heart. I'm going to skip over this. This just illustrates that there are lots of different reasons the mitral valve can leak. And then treatment options, medications. Again, open heart surgery is an option for a lot of patients. But now we have this thing. This is called MitraClip. This is a minimally invasive technique to repair the mitral valve. So again, we took this case to our heart team. Everybody felt that the risk of open heart surgery would be high for this patient, but we can readily treat her valve condition with a MitraClip. This is MitraClip. So this is my side of the device. So it's this thing that has a bunch of cranks and catheters and tubes. The side that goes into the patient is this catheter with a clip at the end of it. Again, we're using a needle to get into a vein in the groin. This vein leads to the heart. We have to cross from the right atrium into the left atrium. There's a very thin membrane there, and we're able to puncture that using a special device that allows us to do that safely. And we get our delivery catheter into the left atrium, and we're able to steer that catheter down towards the mitral valve. Here comes our MitraClip. And we're watching what we're doing using transesophageal echo. So that ultrasound that's in the esophagus, we're able to see very clearly what we're doing. We're able to position the MitraClip in 3 dimensions. And the idea is we want to capture the 2 mitral valve leaflets where the leak is the worst. So here we are aiming for the leaflets. We capture them in the clip. We may have to adjust our position so we can let go, we can release and recapture. And then when we're happy, we close the clip. The valve is still opening fine. As long as we don't put too many clips in, there will be no obstruction of blood flow through the valve, but this will reduce the leak significantly. So you can see on the right, the regurgitation, this is before, and on the left, we have the MitraClip. So, whoops, don't want to watch that again. I'll get in trouble. But we can see here on the right, so this is before. Sorry. Here is the MitraClip procedure. So on the left, we're using three-dimensional transesophageal echocardiography. And you can see our MitraClip here. Below the MitraClip is the mitral valve. We're positioning the MitraClip. You can see on the right, the two leaflets. One is right here, one is right here. And hopefully you can see the MitraClip arms. So here we're below the valve and we're gripping the valve leaflets. And I think this video is not working on the left for some reason, but on the right, hopefully you can see we're halfway closed now. We've gripped both leaflets and we're going to complete the closure. And here we go. So on the left, we see before, again, sorry that the video's wonky. And on the right, hopefully you can see there's almost no leak. We're looking at this yellowish red stuff. This was the leak. And here there's just trivial leak. So this patient had a successful MitraClip procedure. Again, woke up feeling better, noticing a difference right away, and has done quite well since that procedure. So almost out of time. I think I just got the -2-minute warning. So we're going to just zip through some future therapies and be done. So just like MitraClip, we have now TriClip. This really isn't a future therapy because we just started doing this procedure at Queens. So this is treating the tricuspid valve similar to what we just saw in the mitral valve. So a clip, which is very similar to the MitraClip, is positioned in the tricuspid valve and deployed. This is more complex because instead of having just two leaflets, there are three leaflets in the tricuspid valve. Imaging is much more difficult. Fortunately, we have very specialized imagers that can help us see. But the clip technology is very similar. So we're having a great experience with TriClip. This is Evoke. So what about patients that can't get a TriClip? They have severe tricuspid valve disease, but it's not amenable to a clip placement. Evoke is a transcatheter valve replacement. We do not have this yet in the state of Hawaii. There's only a few centers doing this right now, but it's coming. But here you can see the new valve that captures the tricuspid valve leaflets from below. And once the device is in position, the new valve is deployed. Here comes Thomas. This is a slow controlled deployment. And it stays in place because it's grabbed onto the tricuspid valve leaflets. So again, we're not removing the tricuspid valve, we're actually using it to anchor the new valve. And that's what it looks like. So that's Evoke. We have a similar technology for the mitral valve. I don't have a video for that one, but here's the Intrepid valve. This is undergoing clinical trials in the United States right now. So this is not commercially available. But you can see we're crossing from the right atrium into the left atrium and deploying an artificial valve in the mitral position. So this is coming. So in conclusion, the heart's a pump. It's made of muscle and it has electrical and plumbing. There are 4 heart valves: the aortic valve, mitral valve, pulmonic valve, and tricuspid valve. Common symptoms of valvular heart disease, regardless of what type of valve is affected: shortness of breath, fatigue, oftentimes leg swelling. Aortic valve stenosis and mitral valve regurgitation are 2 of the most common valve disorders. Treatment options for valvular heart disease include medical therapy alone for people that can't tolerate a procedure. Open heart surgery is an option for many people, but now we have transcatheter therapies, non-open heart surgery or minimally invasive procedures for most valve conditions. And then the heart team, which I didn't spend a lot of time talking about, but that's critically important in decision making. So anyone coming in that has a valve problem, we're going to go through the heart team process, and we'll have a team decision on recommendation for treatment. Thank you. The last thing I'll just mention.
Thank you.
Thanks.
Ben, thank you so much. He made it sound really, really easy. It's not. But thank you, Ben. Those were amazing videos, and that was a really wonderful talk. Do we have any questions? Oh my God. Okay. Okay.
Yes.
I'm wondering how common is it among seniors to have some calcified plaque? And can we do something maybe dietary wise to uh, tamp it down or get rid of it?
That's a great question. So, very common. So calcified plaque. So this is plaque building up in the blood vessels in the heart, or in the other blood vessels in the body, the aorta or other places. Very common. The condition that causes that is called atherosclerosis. So this is when cholesterol and fat build up in the walls of the blood vessels, and calcium forms after that inflammation process that's caused by that buildup occurs. Calcium, once it's there, it's very hard to get rid of. In fact, there's no good way to get rid of the calcium. There's no medication that can just get rid of it. But what we can do is we can prevent it from forming. So, that's a combination of uh, healthy diet, regular cardiovascular exercise, checking in with your doctor every now and then, getting your cholesterol checked, making sure other medical conditions like high blood pressure and diabetes are under good control. That will help prevent that from happening. If you have calcified plaque already, the best thing you can do is those things I just mentioned to help prevent that from getting worse over time.
What is the average age of your valvular replacement patients? And what is the age of your oldest patient in Hawaii?
Yeah, great question. I couldn't see who asked that, but oh, thanks. Let's talk about aortic valve stenosis. The average age is right around 82 years old. Okay. There's no age cutoff for that condition. So we see people in clinic that are in their 60s. We see people who are in their 90s. And really, the most important thing is how much benefit will somebody get out of that? If we replace the valve, will this really have a positive impact on their life? And that's the most important thing. The oldest person that I've been a part of doing an aortic valve replacement using the TAVR technique was 102. Um, and that person lived another 2 years and felt great. Yeah. It's really about improving quality of life. When you get into that age group, it's every single person that I see, they're not worried about how long they're going to live. They're worried about how good they're going to feel for the rest of their lives. And that's why we do that. Yes.
Folks like myself who have mitral valve leaks are
Yeah.
required to take antibiotics before we go for dental treatments like cleaning or whatever.
Yeah.
And why do those bacteria pose a particular problem for leaky valves?
Yeah. So if you have a leaky valve and it's leaking because there's been work done on it. So if there's artificial material in your heart, maybe you had a valve replacement, maybe you have a MitraClip that we just talked about, or maybe you don't have either of those things, but you have a congenital abnormality of your valve, and the valve's leaking. So what can happen when you have dental work, including dental cleanings? You have your dentist or your dental hygienist scraping your gum lines, cleaning your teeth. Sometimes there's some bleeding. That can happen. But there can be introduction of bacteria from your mouth into your bloodstream. Now, normally our immune system is good about cleaning that up, so it doesn't cause a major health risk. But if we have a valve abnormality, it can. If we have artificial material in our heart, that bacteria can colonize that, it can stick to it, and it can cause an infection. When there's an infection in the heart valves, that's called endocarditis, and that can be very serious. So if you have a valve condition, oftentimes your dentist or your cardiologist will say, "Hey, you got to be on an antibiotic." You take that, 30 to 60 minutes before your dental procedure, and you should be good.
What is the relationship between high blood pressure or low blood pressure and these diseases that you're talking about with the you mentioned that there's a relationship, but I'm not quite understanding,
Yeah.
how it
So
relates.
Yeah, so what we were talking about just a moment ago, atherosclerosis, so that's buildup of plaque and calcium in the blood vessels in the body, including the blood vessels in the heart. So that's a little bit different than the valve disease we were talking about. But chronic high blood pressure can increase the risk of atherosclerosis. Now, what we also know, though, is the risk factors, the things that can cause atherosclerosis, it looks like they're also linked to causing aortic valve stenosis. So similar process in the blood vessels, we think is affecting the tissue in the aortic valves. Other valve conditions are affected less, the impact is less in regards to things like high blood pressure or low blood pressure. But the aortic valve seems to be very sensitive to the similar risk factors that cause atherosclerosis.
Mike.
Puts more stress on the
Yeah.
blood flow. Is that why
Yeah.
it would cause maybe problems with the valves?
Yeah, so when you have high blood pressure, there's more stress on the endothelium. So endothelium is the lining in all of our blood vessels. It's a very thin layer of tissue. The endothelium is very sensitive to blood pressure. So the higher the blood pressure, the longer the blood pressure is too high, so chronic hypertension, the more of a negative impact that's going to have on the endothelium. The endothelium will respond to that by increasing inflammatory markers, which are these tiny molecules that bring in the immune system. And when the immune system comes in to help, it leaves and drops some calcium on the way and plaque.
Was there any bad effects on low blood pressure if your blood pressure is too low or
Yeah,
just high
low blood pressure is not a good thing, but it's probably not going to drive atherosclerosis or calcium buildup.
Thank you.
Yeah.
I was wondering, when people have osteoporosis or osteopenia, they've been asked to take a lot of calcium. How does that impact the arteries and the heart?
Yeah, great question. So it turns out dietary calcium probably doesn't have a major impact on calcium buildup in the arteries and heart. Okay. But we do see, so one thing where we do see calcium buildup at a faster rate are people that have kidney problems. So chronic kidney disease, maybe people who are on dialysis, they'll often be on some calcium modulators, and that can drive increased calcium buildup. But yeah, osteoporosis, they tell you to take a calcium supplement, probably not going to cause calcium buildup in the valves.
I'm going to piggyback on Dr. Hinshaw's question about mitral valve.
Yeah.
I was diagnosed with that like over 15 years ago, but cardiologists have been kind of, poo-pooed it like it's no big deal. And it's a mitral valve prolapse with regurgitation. And I was also told that it's common in almost 20% of women. Can you talk a little bit more about that? And, should I have had some kind of intervention or just continue to live my life?
Yeah. So mitral valve prolapse is the most common mitral valve disorder there is. And you're right, it's more common in women than in men. Mitral valve prolapse causing a mild amount of regurgitation or leak, very common. As we get older, the leak part of mitral valve prolapse becomes more common. But even as we're younger, we see mitral valve prolapse in probably 5 to 10% of people, women more than men. The decision to do something about mitral valve regurgitation depends on how severe is it, and is it having an impact on your life. So it's very common for someone to have mitral valve prolapse. Maybe they have mild mitral valve regurgitation or moderate mitral valve regurgitation. They feel fine. They're going about their lives with no impact. We would just manage that conservatively. At most, we would check in on that valve every 1 or 2 years with an echo and see you in office. But if it's severe or if you're having symptoms from that, that's the trigger for getting workup for repair or replacement.
What's the rate of adverse events with a valve implantation? And after a successful implantation, what's the rate of needing a revision at some time in the future?
Great question. So we're talking about transcatheter aortic valve replacement, or TAVR. So that's the catheter-based valve implant. The risk of major life-threatening events during the procedure, and I'm talking about things like bleeding that would require a blood transfusion, a problem that requires emergency open heart surgery, a problem that leads to death, heart attack, stroke, those types of things. The combined risk of any of those things is 1% in the studies. So we consider that low risk. If you compare that to open heart surgery is going to probably give you, in the best case scenario, a 2 to 3% risk. So the risk I would consider low. One thing to keep in mind for aortic valve replacement is there is a risk of a condition that affects the conduction, the electrical system in the heart. So there's about a 6% chance that after valve implant, somebody needs a pacemaker. With open heart surgery, that risk is about 4%. So there's a slightly improved risk with open heart surgery. But the reason is, I don't know if you remember when I showed you that slide with the electrical system, the conduction tissue in the heart, that goes very close to where the aortic valve is as it goes from the top of the heart to the bottom. So sometimes a valve implant can put excessive pressure on that tissue, which, by the way, is invisible. We can't see that. We just know it's there. And if it puts too much pressure, then that causes a disconnect that requires a pacemaker. Now, after a valve is implanted, what you have is a metal frame, and on the inside, you have a new valve. The valve is made out of tissue that comes from either a cow or a pig, just like a surgically implanted valve. That tissue can wear out over time. Just like with a surgically implanted valve, what we think is that will last on average between 10 and 12 years. If it were to wear out, we can put another one in. Now we have our latest iterations of these TAVR valves. They're designed to resist that. They haven't been around long enough to have studies that tell us exactly how long they're going to last. But I tell my patients, expect to get 10 to 12 years out of this valve. And if there's a problem, we'll put another one in.
I've been diagnosed with supraventricular tachycardia, and based on the chambers of the heart that you showed us, where is the problem with SVT?
Yeah, so supraventricular tachycardia is an electrical problem, and its root is in the atria. So that's where the top chambers of the heart. So here in this cartoon, so these are the upper chambers from the outside. These are the atria. So supraventricular tachycardia, supra means above. Ventricle is talking about these chambers called the ventricles. So supraventricular tachycardia starts up here somewhere. Now there's lots of different reasons someone has supraventricular tachycardia. So there's lots of stuff that can go wrong up here electrically. So I'm not exactly sure what the cause of your condition is, but it's going to be up here somewhere. Yeah. Yeah, so I get questions like this all the time. The questions are, did COVID cause this, or did the vaccine cause this? I'm not aware of any data or evidence that says that the COVID vaccine causes supraventricular tachycardia. Okay. But I hear anecdotal cases like what you're saying, this happened, and temporally it's related, but I don't have any evidence that says that it's related.
We have time for one last question. Sorry, I know there are a lot of hands up, but we're running out of time.
Question I have is, if a 90-year-old with no symptoms besides weakness of the heart, maybe the leakage, what's the time frame for a person needing it at the moment? Because you mentioned that you could do it ahead of time and have it ready to go. If they didn't have that ready to go time frame, what's it looking like?
Sorry, so you mean what's the time frame from when they come into clinic?
When they actually really need it.
Oh, when they really need it. Yeah, so when it comes to valve disorders, if they're symptomatic and the valve condition is severe, getting that fixed early is better than waiting. Because the longer you wait, the more damage it can do to the heart. Now, if the valve condition is not severe, let's say they have moderate mitral valve regurgitation, not severe, they're feeling okay. We actually don't have an indication at that point to do a procedure. In those cases, we would track them and we would, make sure it's not getting worse, make sure they're feeling good. If they need medical optimization, that's something that, we would help with. But we wouldn't intervene on a moderate valve problem because we don't have data right now that says that the benefits of intervening in that scenario outweigh the risks. So we have to be in a situation, whenever we do these big procedures, we want to be in a situation where we know the benefits outweigh the risks. So in moderate valve disease, that doesn't.
And part two to that question would be, could it be the mitral, the tricuspid, or the aortic? Could several of them be leaking?
Oh yeah, that happens quite a bit. The classic scenario is someone has very severe aortic valve stenosis, so the aortic valve doesn't open. That condition is going to have really increased blood pressure inside the left ventricle. That is going to translate into a leaky mitral valve because the mitral valve can't resist all that pressure. That's going to increase the blood pressure in the lungs, which backflows into the right heart. That's going to cause more tricuspid valve regurgitation. So in that scenario, we would start with the aortic valve, and then oftentimes just relieving that obstruction is going to reduce the amount of mitral and tricuspid valve regurgitation. We wouldn't do all three at once. Now, if you're going to have open heart surgery, the surgeon's probably going to do all three at once. But if you're having the catheter-based option, we would probably start with the aortic valve, optimize meds, and then recheck an echocardiogram a month later.
Thank you so much, Ben. As you can see, there are way more questions than time will allow, but thank you for a wonderful presentation. And thank you for coming back to Hawaii so that our kupuna have access to these services.